All right, welcome everyone, and this is a video cast, a podcast for our updates for our local protocols regarding COVID-19 and our modified service delivery. We're going to continue to work on what we provided earlier in the month, and I just want to share a couple of reminders. I'm joined today by Chief Oakley, Robert Moya, Dr. Abraham, and we're going to go through a few of the items and highlight the changes for you over the next few moments. But I want to keep an emphasis on COVID is still out there. It's still affecting our lives. In fact, we've had additional healthcare workers, pre-hospital responders throughout the country who have died from COVID. And locally, we've had additional providers who have turned positive from this. And so what we want to do is make sure that we're taking this seriously. We continue to follow and monitor guidelines. In addition to that, what we're finding is there's a little bit more science and information that's becoming available to us. And some of that information that we talked about early on, like the fear of aerosolized generating procedures and things like that, we want to be cautious, but we're not finding caregivers who are being exposed and contracting the disease from those areas. And so we're going to talk a little bit about those things today. I just wanted to, again, go over the protocol revisions, and we're happy to answer questions. Shoot us a text or email, but really reinforce the idea that COVID is still out there. We have to watch and make sure we're not getting tunnel vision. We have lots of people with what we'll call our normal disease processes, asthma, CHF, who need to be treated and evaluated appropriately. So with that, Ben, do you want to give us a couple of general reminders for us, please?
Yeah, thank you, Dr. Manifold. So the protocol is ready for distribution here. The first thing, and this will be page 2 to protocol U91, which is a COVID-19 community spread modified service delivery document. And so the first thing that we're starting off with reminding everybody is a general reminder on universal care, which Dr. Manifold just alluded to regarding preventing tunnel vision, looking at the big picture, and remembering that our standard everyday routine medical patients are still continuing to occur. And so like things such as heart disease, sepsis, stroke, cardiac arrests, we're still seeing those calls, and we still have to take care of those calls. And we can't be completely blindsided by COVID-19. While it changes a little bit how we're doing certain things, and we have to be careful, at the same time, we still have to treat patients, and we have an obligation to our patients and to deliver the proper care. So some reminders we put in there as an example, someone with COPD that is experiencing, bronchospasm, but there's nothing to suggest COVID-19, beta agonists may still be appropriate. CHF patients, may still require CPAP, outside of the realm of COVID-19. And so the other thing, the next area we go into in this document is going to be regarding cardiac arrests. And so our page 1 of this protocol already gave some general reminders and things that we should do differently on cardiac arrest, like PPE for all of our providers on the cardiac arrest, and considering termination, not transporting, things of that nature. A few other things that we're adding into with this latest update, though, is confirming DNR status during the initial stages of evaluation of cardiac arrest, and also, communicating with family and investigating the patient's known wishes regarding resuscitation. Also, it's a great opportunity for pre-planning exercises. So if there's nothing else that we don't walk away from COVID-19 with, is this collaboration and incorporating everyone in our healthcare systems and our community partners. So as far as cardiac arrest is concerned, this is a great opportunity for everybody to reach out to their local nursing homes, LTACs, assisted living, group homes, anything like that, and educate them on the Texas Out of Hospital DNR form, processes for it, and identifying with them how they identify those patients in their facility, where that documentation is kept, is it in a mechanism that can be easily accessed in the setting of a cardiac arrest, and things of that nature. So those are our first 2 things regarding this protocol update.
Great, Ben. Thanks for the quick review. And Robert Moya, why don't we just transition right into kind of STEMI, some of the cardiology manifestations and things that we want our folks to be aware of.
Right, we'll go through that. So one of the first things we need to understand is that again, COVID is evolving. The knowledge that we're seeing, studies that are being done, and one of the things that we've noticed is that there are mimickers of STEMI on patients that potentially have COVID, usually as a result of myocarditis, microemboli syndrome that they might have. That doesn't mean that every STEMI is a COVID patient and every COVID patient is a STEMI patient. So we still need to do a proper assessment of the patient. We still have to do a 4-lead. We still have to do a 12-lead. We have to make sure that the history is extremely important to us. Again, your EKG findings are going to potentially mimic a STEMI. This means that we have to make sure that we choose the appropriate destination for our patient, preferably someone that might have a PCI. Now, granted that you might call in a heart alert, you might not call in a heart alert, and the hospital itself will upgrade it. Don't be too concerned when that happens. One of the things that we are noticing is that the cardiologists right now are really not doing any intervention type PCI. So again, go with what your assessment shows you, look at what your history shows as well, and treat the patient appropriately according to what you have.
Robert, thank you. I just wanted to clarify a little bit on the PCI component that the cardiologists are trying to get additional information and make sure it's appropriate to take the patient emergently to the cath lab. So they may stop off in the emergency department and be able to do additional evaluations such as laboratory testing, echocardiography, get additional history before they rush the patient off to the cath lab in these days of COVID. So more information to follow, but that is a consideration for right now. And we don't want you to be irritated or upset when you call in a heart alert and you're stopping off in the ER for additional evaluation and things. So great. Dr. Abraham, we're going to give you the bulk of the areas to talk about regarding respiratory and pulmonary management with COVID-19 and some of the changes and considerations that we're putting into place and helping just widen and broaden the knowledge of our responders for us today. So thanks.
Sure. So this is obviously one of the more concerning areas of managing these patients, I guess, just because it tends to be the area that increases risk to us as the providers as well as other people in the vicinity. And I think the most important thing to emphasize is, well, two things. One, we still need to do the right thing for the patient, regardless of those concerns. And two, as long as you're wearing your appropriate PPE, it's appropriate to do anything that's necessary to care for these patients because you're well protected as long as you have all of your appropriate PPE on. So keep those principles in mind. Ventilation and oxygenation. So hypoxia in these patients seems to be one of the lead presentations. And we're still learning a little bit about how best to manage it. One big thing to remember is that we should not be intubating these patients just because they're hypoxic. This is going to require you to assess the entire picture, to look at everything about the patient, including their work with breathing, what their end-tidal CO2 levels are looking like, how well their less invasive mean ventilation, things like that. Nasal cannula works well, manual breather works well, CPAP and BiPAP seem to have an important role in improving oxygenation in these patients, improving their work of breathing, and preventing them being up on a ventilator. Keep in mind that once you've placed the appropriate oxygen modality on the patient, you can then cover it with a surgical mask, and that will help reduce the aerosolization as well. I don't want you to get laid back and casual about things, though, once you, as long as you're treating them in where they've spent a lot of time, the air is probably going to have a good deal of aerosolized particles in it already. So just because you've covered up the oxygen source doesn't mean that you're home free. In terms of medications, there's a number of different medication changes that we're looking at here. On beta agonists, if the patient has their own metered dose inhaler with a spacer, that is preferable. 4 to 8 puffs of the inhaler will still get the patient about as much as a regular nebulized treatment would do, with much less risk of aerosolization. And be sure and take, if the patient has any kind of inhaled medications of any sort, albuterol, there's some steroid inhalers, things like that, be sure and take all of those to the hospital with the patient just so the hospital can continue to use those on the patient as well. Steroids seem to increase the risk of viral shedding in these patients, so we're recommending not to use steroids in patients where you have a high suspicion for COVID. If you don't have a high suspicion for COVID, remember that steroids are still tremendously beneficial for patients with just plain COPD and asthma, and you should still be using those in those patients. If your agency carries terbutaline, this is a little bit of an old school treatment, but tends to work really well as a smooth muscle relaxer and helping to open up the airways in these patients. Epinephrine does something very similar. I know there's traditionally been some concern about the effect, the cardiac effect, especially in older patients. If you have a patient who's truly hypoxic and struggling, the other thing old to diseased hearts don't tolerate very well is hypoxia. So if you need to give them epinephrine in order to improve their oxygenation, that's perfectly acceptable to do. Just keep in mind the patient's cardiovascular status. Fluid resuscitation, traditionally we've preached that 30 cc's per kilogram normal saline or other crystalloid kind of bolus. What we're finding with COVID patients is that we can get them fluid overloaded very easily, and that causes a lot of problems down the road. If the patient is actually hypotensive, go ahead and give them fluid resuscitation as needed to fix that hypotension, but don't give them fluids just because and stop once you get their blood pressure corrected. Proning patients has been a huge topic of discussion over the last couple of weeks. Ventilated patients should absolutely not be proned in the field. This is a complicated procedure, even in the hospital, even with all the appropriate fancy turning beds and lots of people to help with the procedure and stuff like that, and it's absolutely unsafe to do it in the field. However, if you have an awake patient, proning them may be a very viable option. That basically is telling them, hey, put yourself in the position of comfort. Whether that be face down, a lot of people are finding that laying the patient or having the patient lay on the right side tends to work really well, and that's in addition to whatever oxygenation you're providing them through nasal cannula or non-breather. Non-invasive ventilation, we talked about. Filters, if you have a and when you're back, remember whereas you can have some air being kind of around the cuff there. For intubation is still a perfectly safe and appropriate thing to do on these patients if you're wearing your appropriate PPE. And remember that a cuffed endotracheal tube seals off the airway and there's no more aerosolized particles getting out at that point. And then on ventilation management, you're going to want a slightly higher tidal volume, but you're going to try and keep the PEEP low. And that's actually different from what was originally thought on this. Originally, back when this first started, we thought you needed a fairly high PEEP. And the recommendation now is to try and keep that PEEP down as much as possible. And then don't forget to provide adequate sedation for those patients with opiates if possible.
Yeah, and I'll just add, while we're changing pages here on the screen, being able to, again, think back when this initially came out, we had a lot of paranoia about our, aerosolized generating procedures and things. And again, the preliminary information, things that have come out right now show that we're not contaminating folks. We still want to be cautious and do all the things that you can in order to facilitate the management of those folks and minimize your risk as a provider. But again, some of the things that we initially talked about of not doing any nebs and things like that, particularly in our response area, are valuable to continue to treat the patient for their underlying disease process, but let's do it in as safe a manner as possible and things. So good. Any other thoughts or questions or from folks?
Yes. So those agencies that currently do not have terbutaline, do we suggest that they go ahead and go and make the purchase for the terbutaline? Is this something that is going to be a short-term treatment that we should look at, or maybe a long-term treatment that we'll be looking at for?
Yeah, so the terbutaline is an acceptable substitute at this point in time. I don't imagine that will continue to be a long-term solution for this. This was a manner of trying to give a parenteral medication instead of an aerosolized generating procedure. And so we wanted to give options. And again, as we're getting more information and experience with this, I think we're okay. But terbutaline is an acceptable option, and it's up to the individual agency's discretion, as we talked about previously, in the service they want to provide to their citizens and things. So, other thoughts or anything else you guys want to emphasize at this point in time?
Dr. Manifold, I'm sure somebody might ask, and we can be sure to incorporate this in here, but do we have a credentialing level set regarding the tributyling?
Yeah, it should be at the paramedic level for the time being and things. So,
All right.
okay. All right. Anything else we should cover for the folks that are out there at this point in time? That is it. We thank you and we appreciate you taking the time to listen to this. Again, if there's questions, please feel free to email, text, give us a call, help us clarify things for you. But again, we want to provide as much up-to-date information as we can. Recognize that this is changing, and what we say today may not be accurate tomorrow. And so we're learning more and more as we go. We want you to be safe out there, wear your PPE, and do good things. Thanks so much. Appreciate it.